Right. So, good evening, everyone. I will be speaking about chemical injuries of the eye. So, this presentation is meant to be a brief overview. I will not be going into a lot of detail because that is not required for your FRCS exam. However, some of the points here will be of use to you in the daily practice as well. I will be very happy to ask any queries. Please don't hesitate to stop me at any point. Okay. So, the objectives of this presentation are fourfold. First, we will discuss the types of chemical injury and how to grade them. Next, we will discuss the management of acute phase. Now, this objective is the most important for your oral exams. Next, we have the management of chronic phase. And lastly, I will discuss the case scenario which I was presented during my viva. So we begin with the types of chemical injury. So whenever a patient presents to you with chemical injury, you need to understand that uh, not just the chemical itself, there are some other points which you need to keep in mind to determine how bad the injury can be for the patient. First, the pH is obviously very important. The higher or lower the pH, the worse it is. Next is the volume. Obviously, the more the chemical, the worse it is for the patient. Then comes concentration, duration of contact, inherent toxicity of the chemical. All of these factors contribute to how severe the chemical injury can be for the eye. So this table is taken from the American Academy of Ophthalmology, the cornea book, and it sums up the common chemicals which cause injuries to the eye. So the chemicals can always be divided into alkali and acid. Among the alkali, the most important ones which we need to remember are sodium hydroxide and calcium hydroxide. Uh, we encounter a lot of patients who have injury due to plaster, mortar, cement. All of this is because of lime or calcium hydroxide. And patients who have injury due to drain cleaners will be having this because of sodium hydroxide or lime. Among acids, the commonest acid injury which we encounter is due to acid from the car battery or inverter batteries. So this will be sulfuric acid. Now, alkali injuries are the most severe chemical injuries. They are always worse than acid injuries. Why? Because alkali causes saponification of the fatty acids in the cell membranes. So, what this does is it disrupts the cellular membranes and the chemical readily penetrates the stroma and ends up destroying the proteoglycans, which is the uh, you can say the heart of the stroma, and as a result the stroma can melt very quickly and it ends up in a very bad shape for the patient. It can also penetrate through the endothelium into the anterior chamber, especially for stronger alkalis, and once it enters the anterior chamber it can cause a lot of further damage as well. Now, acid injury is less severe than alkaline. It denatures and precipitates proteins in the tissues. However, since it denatures and precipitates proteins itself, it creates a barrier to its penetration. As a result, there is a lower chance of corneal melting or intraocular penetration. An exception to this is hydrofluoric acid, which has a very strong penetrating capability through the cornea. The poorest visual prognosis occurs in patients with extensive limbal epithelial damage. So I will be explaining this later. Now, the reason this happens is because the limbus contains corneal epithelial stem cells, and blanching occurs when the vascular supply to this critical area is disrupted due to a chemical injury. Eh, there will be death of vascular endothelial cells in the conjunctiva, and eventually this can lead to limbal stem cell deficiency. So what happens is that because the limbal stem cells are now deficient, the corneal surface epithelium gets repopulated with undifferentiated conjunctival cells. And this leads to a vicious cycle. There will be poor epithelial adhesion, recurrent breakdown, and chronic inflammation. Additionally, if the chemical manages to penetrate into the anterior chamber, as I mentioned earlier, it can result in cataract formation and secondary glaucoma by damaging the trabecular meshwork. So, how do we classify chemical injuries? The old classification was the Roper Hall classification, which we have all studied. Now, the Roper Hall is very simple. There is nothing much to read into. There are four grades. It is classified on the basis of what are the findings of the cornea and what are the findings of the conjunctiva and limbus. So there is no limbal ischemia, less than one third to half, and more than half, as you can see in the images on the right. So, however, there is a drawback here. If you look at the prognosis which is mentioned on the extreme right, Roper Hall classifies all grade 4 injuries as poor prognosis. Now, this was the old concept. However, nowadays, this is not true. A lot of patients who will have more than 50% limbal ischemia can still have a good outcome. So this is where the Dua's classification comes in. This is the original publication by Dr. Dua, which was published in the VJO. And what they proposed was that instead of the term limbal ischemia, they will go for something called limbal involvement and conjunctival involvement. So any chemical injury was classified on the basis of these two headings, limbal involvement, conjunctival involvement. And you determine the prognosis based on these two findings. Uh, so this is an example of what a grade 1 ocular surface burn will look like in DUAs. So DUAs classification is very important because nowadays we follow this for grading our chemical injuries in most centers across India at least. In grade 1, you will see the patient will have an epithelial defect. On fluorescence staining, the epithelial defect can be seen. However, there will be no limbal or conjunctival involvement. The prognosis in these patients is very good. So this is known as a grade 1 DUAs. Now, when you come to suppose a grade 3 DUAs, for example, you will see that here the fluorescence is staining the the cornea, the limbus, as well as the conjunctiva. So now, since the limbus and the conjunctiva are both involved, you are ending up with a chemical injury which needs to be graded in the DUAS classification. And how do we do this? So you are having roughly 4.5 clock hours of limbal involvement. So this becomes a grade 3 injury. And along with this, you are having a roughly 30% of conjunctival involvement. Please remember, these numbers are not exact. So you have to evaluate them on the slit lamp, and you have to follow the clock hour rule to determine how much percentage is involved. So since you are having more than 3 clock hours of limbal involvement and around 30 to 50% of conjunctival involvement, this comes as grade 3. So sometimes it may happen that the limbal involvement is more, but the conjunctival involvement is less. In that case, the limbal involvement takes priority when you grade the chemical injury. Now we come to something which is known as the grade 4 duas. So now if you see this patient, this is all these photos are taken from Dr. Dua's original article. So this patient had around 7 clock hours of limbal involvement. By the Roper Hall classification, this patient is supposed to have a poor prognosis. However, this patient ultimately had an excellent outcome, as you can see in the lower image. He underwent autolimbal transplant, and following this, he underwent a full thickness corneal transplant. Now, this is why Dua's classification is important. However, there is something here which is grade 6 duas, which we call which we know as grade 6. So for grade 6 duas, we need to understand that the prognosis is actually very poor. This is something which really correlates with grade 4 in Roper Hall, so to say. The total limbus is involved, as you can see with the staining, and the total conjunctiva is involved. So the outcome for these patients are always very poor because there is nothing to cover the epithelium, neither cornea nor conjunctiva. So while this classification is not asked in detail during our FRCS, this will be important to you in your day-to-day clinics. Hence, I have spent so much time on this. Uh, just to reiterate, the difference between DUAS and Roper Hall is this. Roper Hall has 4 grades. The fourth grade will have any patient with more than half limbal ischemia. But what Dr. Dua proposed is the fourth grade in Roper Hall can be broken down into 3 further grades, or grade 4, 5, and 6 in Duas, based on clock hours of limbal involvement of 6 to 9, 9 to 12, or total. And he counted this as limbal involvement and conjunctival involvement. The word involvement is very important. And Roper Hall is ischemia. The reason is any patient with fluorescent stain of the limbus is counted as limbal involvement as per Dua's classification. So fluorescent staining of the limbus may or may not indicate limbal ischemia, but you cannot determine it on the first visit. It's very dynamic. So you need to repeat this grading every time you see a patient in your clinic on the follow-up visits as well, because the grade keeps changing according to the fluorescence stain. Okay, so enough about the grading. Now we come to the management in the acute phase. This is the question which is actually asked in FRCS. So immediate copious irrigation of the ocular surface with water or balanced saline solution is the most important step. So this is the first thing which should come out of your mouth. Immediate irrigation of the surface. And what the next question will be, what fluid will you use? So if you are in a hospital setting, you can use normal saline, you can use ringer lactate. It will be ideal if you get access to BSS. However, if you don't have any of that, use tap water. It doesn't matter. But use whatever you have, and it should be the first thing you do. How do you irrigate the patient? This is also asked sometimes. You open the lids with a retractor, put a topical anesthetic, use a handheld IV tubing or something known as a Morgan's lens. Morgan's lens is a modified scleral lens which you place over the surface. However, in most centers, we will have the handheld intravenous tubing, which is more commonly used. And you continue irrigating the patient until the pH of the conjunctival sac normalizes. So how do you determine whether the pH is normal or not? You can check the pH with a simple urinary pH strip. If you do not have access to the pH strip, you should prefer to over irrigate rather than under irrigate the surface. And a common rule of thumb is that if you don't have access to any such pH strips, you irrigate the eye for at least half an hour. Once you have finished irrigation, now you move to the next step, which is removal of particulate matter. These particulate matters will be embedded in the ocular surface or in the tarsal conjunctiva, and they will cause further toxicity. So you remove the superficial ones with cotton-tipped applicators or forceps. Next, you evert the upper eyelid and you search for material in the upper fornix as well. Be sure to do a double eversion. Have Ma's retractor, well and good, you can use it. That will be the best option. However, if you don't have access to it, you can fashion one from a simple paper clip as well. These pictures are taken from the American Academy of Ophthalmology. You can look it up. It's very simple to use and it can be a lifesaver in settings where you don't have access to DMRs. Next, you sweep the fornices well and you debride any necrotic corneal epithelium which you can see on the slit lamp. So, what are the goals of medical management in acute phase? There are three primary goals. First and foremost is to decrease inflammation in the eye. Second is to prevent stromal breakdown. And third is to promote re-epithelialization of the cornea. So how do we decrease inflammation? Whenever there is an acute alkali or for that matter an acid burn also, an intense polymorphonucleoside infiltration occurs. And this will deliver proteolytic enzymes and this in turn dissolves the corneal stromal collagen. In this setting, corticosteroids are excellent inhibitors of polymorphonucleosides. And intensive treatment with a topical corticosteroid is recommended for up to 10 to 14 days following a chemical injury. So these two lines are very important. So in the acute phase, when they ask you which drugs to give, topical corticosteroids should be the one of the first uh, drugs which you mention. And the duration is also very important. I was asked a duration in my viva. So it is recommended that you use it only up to 10 to 14 days in the higher dosage, and following that you taper rapidly, because it is a very fine balance. While corticosteroids will contribute to inhibition of polymorphonucleosides and control the inflammation, it can also cause stromal thinning. So you need to balance it out. Once the initial 10 to 14 days have passed, you rapidly taper and stop it. Next objective will be to prevent stromal breakdown. So if you see a chemical injury where you are suspecting that the stroma is melting, then in this case you use oral tetracyclines and topical sodium citrate 10%. 1 to 2 grams of ascorbate has been proposed and has been used conventionally by us for a long time. Uh, it is it has been shown to give good results in patients who are having more severe chemical burns. So these will help you in preventing the stroma from breaking down. Oral tetracyclines or oral doxycycline. How does the doxycycline work? It inhibits the matrix metalloproteinases. Topical sodium citrate will chelate any extracellular calcium. This will inhibit any degranulation of nucleosides. And ascorbic acid, when you are prescribing to the patient, it should be in a proper dosing. You have to give it at least 4 times a day. The dose is 1 gram to 2 gram. So please keep that in mind. One tablet a day will not do the job. Other than this, non-preserved topical lubricants and prophylactic topical antibiotics are supposed to be given in all patients with chemical injury. So they help in the comfort and they will prevent any secondary infection respectively. Now we come to the third objective in the acute phase, which is to promote reepithelialization. What do we do here? We will uh, use modalities like bandage contact lenses, amniotic membrane graft, tarsorrhaphy, or tenonplasty. So bandage contact lens is important here. In most of our settings, we may or may not have access to an amniotic membrane graft. However, if you have a BCL and the patient is having a large epithelial defect, the BCL serves two purposes. Patient gets immediate symptomatic relief and the shearing effect of the eyelid is gone. So the epithelium heals quicker. Amniotic membrane graft is used in acute settings if there is a severe chemical injury. Otherwise, what I prefer to do is I will wait for at least a week. I will place a BCL in the on the immediate presentation. I will wait for a week. If after a week I see that the epithelial defect is healing very slowly, then I will go ahead for performing an amniotic membrane graft. Now, the AMG serves two purposes. One, it absorbs any inflammatory mediators and it helps to quieten the eye down in a much faster manner compared to just leaving it alone. And the second is obviously it acts as a scaffold for the epithelium and the reepithelialization occurs in a much smoother manner. Third is tarsorrhaphy. So if you are having a severe chemical burn and eventually you are going for an AMG, it's always a good idea to do a tarsorrhaphy along with it. Do a temporary tarsorrhaphy, paramedian, lateral paramedian or lateral. It reduces the exposure of the ocular surface and it helps in the surface stabilizing in a much quicker manner. Lastly, we have tenonplasty. Now, tenonplasty is not done in all patients. Tenonplasty is reserved for the worst injuries or grade 6 of DUAs when you have 12 flocas of limbal ischemia. So what you do is you don't have any conjunctiva left, right? So you will have to go beyond the conjunctiva, expose the tenons, pull it up and suture it towards to the limbus or the perilimbal area. So this is a last ditch attempt to promote some vascularization of the surface. And the most neglected thing I would feel in chemical injuries is controlling the IOP. We often miss this because we are so focused on the chemical injury itself. But chemical injuries will cause massive increases in intraocular pressure in some cases, which need to be controlled. And I prefer to use oral carbonic anhydrase inhibitors to avoid any toxicity from topical medications. And you can give topical medications as well if the injury is mild. If you have a mild chemical injury or a grade 1 or grade 2. If you have a more severe one, the patient is already on a lot of drops. So Diamox will be a better idea. And we should also prescribe topical cycloplegics. This has nothing to do with IOP, but it reduces the discomfort to a major extent in the patient. This is an algorithm which I have copied from an article by Baradar Rafi et al where they have broken down how you manage acute ocular chemical injury. So, first and foremost, you irrigate the eye, you prognosticate the patient using DUAs or Roper halls. After this, you start topical corticosteroids to control inflammation, and Next, you promote reepithelialization by doing by placing bandage contact lens, amniotic membranes, or do a tenonplasty or tarsorrhaphy as needed. Next, you will have to prevent stromal breakdown. So you prescribe frequent lubricants, doxycycline, vitamin C, sodium citrate, etc. So this is a table summing up the same thing. I if you do have the time, please go through this article. It sums everything up in a very beautiful manner. So we are done with the acute phase, which is the most important for our Viva. Now we come for management of chronic phase. So if you answer the acute phase questions properly, the examiner will next ask you what are the long-term sequelae of chemical injury. So this is one of the commonest long-term sequelae in a severe chemical injury. You end up with symblepharon. So how do you manage this? You have symblepharon, uh, you have a cicatricial, you have cicatricial entropion happening, you have trichiasis happening, and all of this will have to be managed before you go ahead and manage the surface. So Symblepharon or any surface abnormalities are major contributing factors to corneal complications. You cannot have a good surface without managing the adnexa or the Symblepharon. Now, when you have a mild or moderate symblepharon, the fornix can be reconstructed with the help of amniotic membrane transplantation. You excise the symblepharon and you replace this with an AMG. If you have a severe or extensive symblepharon, then you don't have a choice. AMG will not do the trick. You need to place new mucosal tissue. So you will have to excise the entire symblepharon and you will have to place a mucous membrane graft if it is a bilateral chemical injury. If it is unilateral, you can use a conjunctival autograft from the contralateral eye. However, it is very important that you manage this, as I am reiterating again and again. Until and unless you manage the symblepharon and create a deep and healthy fornix, no further surface interventions will be of significant use in this patient. So your first chronic sequelae is symblepharon and ankyloblepharon as well as ocular adnexa problems. The second chronic sequelae is glaucoma. Now, secondary glaucoma can have an incidence of over 20% in these patients who have chemical injury. And since you are focused on the ocular surface, as I mentioned, you will miss this. What happens is the secondary chronic inflammation due to chemical injury will lead to synechia and angle closure. This is going to end up damaging the trabecular meshwork. It can cause severe uveitis. Additionally, you are using steroids, and all of this can finally end up with the patient getting chronic glaucoma. Now, how do we manage this? Since glaucoma in these cases is very difficult to treat, and the surface is already compromised, long-term topical anti-glaucoma medications may end up doing more harm than good. So procedural interventions are generally considered earlier in these patients. You cannot do a trab in these cases because the conjunctiva is already scarred. So you will end up doing a tube or a shunt procedure. Cyclophotocoagulation is indicated in severe burns when there is advanced conjunctival shrinkage. And this does get the job done in a lot of severe grade 5 or grade 6 chemical burns. So we have dealt with two of the chronic sequelae, the symblepharon and glaucoma. Now we come to the third chronic sequelae, which is limbal stem cell deficiency. Now, once you have limbal stem cell deficiency, what happens is the corneal epithelial cells cannot be regenerated. So the conjunctival tissue now migrates towards the central cornea in a process called conjunctivalization. This word, conjunctivalization, is the hallmark of LSCD. Now, LSCD can be a limbal stem cell deficiency. I am calling this LSCD for the class. LSCD can be either partial or complete. So the image on the right is showing a partial LSCD. You can see the pseudopterygium forming on both sides. This is again a hallmark of chemical injury. So it is sparing the visual axis. The image on the left is showing what a complete or total LSCD looks like. Look at the conjunctivalization and the complete vascularization of the surface. So you will have a complete loss of the palisades of Vogt. The epithelium will become opaque. If you do fluorescence staining, you will get a board-like appearance. There will be persistent epithelial defects, superficial neovascularization, and since you have a non-healing or persistent epithelial defect, you will end up with a corneal melt, which results in stromal scarring, neovascularization, and so on. So all in all, a pretty ugly picture for the patient. So how do we manage this? Sometimes just observing is enough if you have a unilateral central cornea sparing limbal stem cell deficiency. Leave the eye alone. There is no need to interfere. If you are having a unilateral total LSCD, then you go ahead and perform something called as auto slit, which is simple limbal epithelial cell transplantation, or a CLAU, which is a conjunctival limbal autograft. If you have a bilateral total limbal stem cell deficiency, you can do something called as an allo slit. Allo means you have to take the graft from someone else. Now, what happens in most of the patients which we will encounter is you will have a unilateral chemical injury. If this unilateral chemical injury patient has a total LSCD, you simply have to take a graft or a limbal biopsy from the contralateral healthy eye and transplant that limbal epithelium to the surface of the eye with total LSCD. This is autoslit. In case of bilateral LSCD, you don't have access to healthy tissue from the patient. So you will have to take a limbal biopsy or graft from a first degree blood relative of the patient and graft it onto the surface. Regardless of whatever surgery you choose to do, surgery should be delayed until ocular surface inflammation has subsided or is well controlled with medications. Unless you have a quiet surface, you will never get good results.
Uh,
And
Excuse
all
me.
eyelid abnormalities. Hello?
I just want to ask if there is surface melting, corneal melting,
Hmm.
is there stromal melting, then amniotic membrane transplant should do early or we should wait?
If you are having a corneal melt, yes, of course, then
Mm.
amniotic membrane has, if you are noting there's a corneal melt, then amniotic membrane and tarsorrhaphy should be done immediately. You don't wait for
Immediately.
it.
Yeah, okay.
Yes, yes, yes. Don't wait for it because you are going to lose the eye otherwise.
Okay.
If
Thank you.
necessary, you do a multi-layered amniotic membrane, but
Okay.
finish it off. Otherwise, you will simply lose the eye. Okay. So, right. So all eyelid abnormalities should be addressed. And once you have done all this, you will now have a chance of saving the eye. So how do you, the reason why I am harping on about simple limbal epithelial transplantation is because this procedure is very simple, cost effective and easy to do. Uh, Previous to the introduction of slit into common parlance, there were multiple other limbal procedures like cultivated limbal epithelial transplantation or conjunctival limbal autograft. However, slit has some benefits which are making it the superior choice in most cases of chemical injury with LSCD, which you will encounter. Now, SLED was actually discovered by Dr. Sayan Basu et al. So they are a group who handles ocular surface at LV Prasad Eye Institute, Hyderabad, and they came up with this surgery. What they do is that they will actually take up the limbal graft from the healthy eye of the patient who has a chemical injury. Supposing the right eye has a complete LSCD, they will take a limbal biopsy of 1 clock hour from the contralateral healthy eye. They will take the graft up, they will cut it up into small pieces, and they will place it over an amniotic membrane scaffold on the eye with total LSCD. So as you can see here, if you look closely, these are some examples of patients who had total LSCD which did not work out even with a corrected limb transplantation or CLET. So they went ahead and did a slit in this. So you can see the small white colored dots here. These are the limbal epithelium which has been harvested from the contralateral eye. They have placed it over the eye with the chemical injury and they have started the patient on topical steroids and antibiotics. As time has passed, you can see that the limbal epithelial cells have been taken up by the cornea and the scarring has disappeared. So the result is almost magical if you choose the patient correctly and the procedure is carried out properly. So now you have managed the lids, you have managed glaucoma, you have managed LSCD. You have a healthy surface, good lids, and a good fornix. So what next? Supposing you are able to manage the fornix properly and LSCD has also been managed, but the scarring is very deep. There is no superficial scarring in this case. Suppose the scarring has occurred in the mid stroma or the deep stroma. So LSCD can't help you with this. You can a slit can't help you with this. It will give you a good surface. So now you have to do a keratoplasty. Now keratoplasty has, as I said again, you manage the LSCD first, or your keratoplasty will fail. If you don't have a healthy limbus, there is no chance of the graft surviving. So, and it has to be a staged procedure. A lot of these patients will also require systemic immunosuppression because these are high risk grafts. So you do a slit, you wait. If the surface clears up and the cornea is clear, do nothing. If the surface is good now after slit, however, there is deep scarring, then you have to go ahead and do a keratoplasty. And finally, we come to keratoprosthesis, which is absolutely the last resort in these patients. And we have to perform this procedure when the patient suffers from repeat corneal graft failure. As I said, these patients are very difficult to manage. So in spite of the best efforts, the graft may end up getting rejected, or the surface may not be good enough in the long run. So you will have to go ahead and do something called a Boston type 1 keratoprosthesis. Kpros are known as mainly two types, Boston type 1 and Boston type 2. So Boston type 1 is the most widely used. For the FRCS exam, just the word keratoprosthesis is enough. Or at the most, maybe Boston type 1. I have not faced any further questions about it. However, just for general knowledge, if you do encounter a patient with keratoprosthesis or you have to counsel a patient for it, please remember these patients require lifelong follow-up and they will require lifelong antibiotic prophylaxis. The problem with keratoprosthesis is that they often melt and they are very predisposed to secondary infections. So you need to be in close follow-up. And while they work out, while when they work out, they give excellent results, and it is an absolutely transformative surgery, life-changing surgery for the patient. The outcomes can be really bad if they are not managed properly or kept on close follow-up. The commonest complications which you will encounter with a keratoprosthesis, just for general knowledge, is glaucoma, which is intractable and very difficult to treat, and retroprosthetic membrane. So these things are factors which you need to keep in mind when you explain to the patient. And this is again a table taken from this excellent article, uh, and it sums up all the measures which I spoke about. Whenever you are dealing with a chronic phase or the chronic sequelae of a chemical injury, there is a typical order for intervention. First, you correct the eyelids. Second, you manage glaucoma. Third, you go ahead and perform ocular surface reconstruction or transplantation, as mentioned, by that is do a slit. And in the end, you come to a keratoplasty or a keratoprosthesis. And this is again the algorithm. So restore the fornix, manage the LSCD, manage the glaucoma. We have gone through this, and you can go through the article. They have all these algorithms. So what questions did I face in my Viva? This is the last part, and I will be wrapping up. I was given a written scenario which just said a young male presents to you with an injury to his left eye with caustic soda. How will you manage it? So, would anyone like to answer this question after the class? Matlab the class from what they have heard in the class. Would anyone like to practice?
Yes.
Yes, please go ahead, doctor.
Okay. First, I would like to check the pH of the pH. Then copious irrigation with a balanced salt solution
Hmm.
for about a half an hour until the pH
Hmm.
becomes 7.
Great.
Means we have to avoid the lid, look for any materials, and fully wash the irrigate the fornix and
Hmm.
surface. Then
Excellent. After that,
corticosteroids should be started.
okay.
Then antibiotics,
Hmm.
preservative-free lubricants,
Right.
Then while washing, you have to swipe this surface with a rod to prevent any semblifron formation.
Okay, fine.
Then this to prevent the stromal melt, you have to start on tetracyclines.
Right.
Then
You're doing well, doctor. Anything else you would like to add?
vitamin C 1 gram, 1 to 2 gram.
Okay, great. Anything else?
Acetylcysteine drops you can start.
Fine. So this is the management. Yeah. So you have covered most of the points. This is how we manage the acute phase. One point which I need to mention here is when the patient presents to you first, you have, while you did mention the everything correctly, you have to add that you will grade the chemical injury.
Okay.
That needs to be answered. That needs to be one of the first things you do once you see the patient on the sit lab. You grade the chemical injury, right?
Okay.
So this is a flowchart which I've taken from an article by Sharma et al. And this discusses how you manage acute ocular chemical burns. I have kept this flowchart because they mentioned the drops and the dosage, which might be helpful to you, and it can help you answer in the Viva better. So when I faced this question in the Viva, my answer was stepwise. So you will have to first evaluate the patient on the sit lamp, check for the do the fluorescence staining, grade the chemical injury. You ask the patient what chemical has hit the eye, whether he has got any vessel or bottle. Sometimes they bring the bottle of the acid or alkali which has gone into the eye. If you have that, you document that. What was the quantity? What was the amount of the fluid which went in? Everything needs to be documented. And simultaneously, you start the irrigation part. So while you are talking to the patient, you start making arrangements to start the irrigation. You put topical anesthesia, put a speculum, and then you start irrigating. You check the pH at regular intervals. Keep irrigating till the pH comes to 7. If you don't have pH strips, just keep irrigating for 30 minutes. You invert the lids, remove the particulate matter, and once you are done with all that, then you start the medications, which Dr. Remya has already described. So this flowchart sums up everything nicely. And just one point one extra point which I will add is always mention the management of raised intraocular pressure. This is very important in the Viva because in FRCS exams, they want to see that you are a safe doctor. So never miss that you need to manage the intraocular pressure. Always mention, sir, I would like to answer, mentioned everything like topical artificial tears and steroids and homatropine and moxie and everything. In the end, you mentioned that I will also add oral carbonic anhydrase inhibitors as I will expect a raised intraocular pressure in this patient in the acute phase. Okay, thank you. So that's the end of my presentation.
One
Yes,
question.
any question?
So
Yeah.
in any chemical injury, will start topical or oral anti-glaucoma medication?
I would say if it see, this varies from specialist. I prefer topical anti-glaucoma medications if it is a superficial grade 1 or grade 2 chemical injury. Because in these patients, in grade 1 to grade 2, I will not give them a lot of extra medications like topical sodium citrate and so on. It's not required. So I will give the topical medication load is less on the eye. So I give topical timolol in these patients twice a day. However, if you are having a more severe chemical injury, I will always give Dimox because I will expect a greater rise in the intraocular pressure as well, and the patient will be instilling a lot of drops in his eye. Okay, so grade 1 or 2, topical anti-glaucoma medications. Grade 3 or more, I go for oral carbonic anhydrase inhibitors. I'll give Dimox. However, for the purpose of Viva, just mention Dimox for anything, for all the grades which they ask. Okay.
Thanks.
Hmm. And you need to keep checking the IOP whenever the patient follows up. Very important. Okay. So does anyone else have any queries?
Sir, just have a doubt.
Yeah,
Um,
please.
so we keep the patient on Predfort or Dexa, right? So when we are after 2 weeks, should we change to FML or some weaker steroid, or should we just taper the Predfort?
You don't need to change the steroid to a weaker steroid. You can just taper it off rapidly. So you can use either Predfort or dexamethasone, right? So the reason we use Predfort or Predase or prednisolone acetate eye drops is basically because that is it's supposed to have a uh, lower steroid response in case the IOP spikes. And it is convention. We have seen most of our seniors use prednisolone acetate eye drops in acute chemical injury and it just gets passed on. However, there is no harm in using dexamethasone eye drops. Personally, I would say dexamethasone eye drops have one advantage. Their drops are clear, so they don't cause any discharge or any matting of the eyelashes. So the patient is happy because of that. And either way, whichever steroid drop you use, once the initial 10 to 12 days have passed, you taper it rapidly. So I prefer to use it 2 hourly or 8 times a day initially, and after the first 10 days are passed, I just taper it off to 4, 3, 2, 1, 5 days each. And I finish it off. There is no need to switch to a weaker steroid. If you
Is
do
that
get a steroid response, just keep the patient on topical AGMs till the steroids are done.
okay, sir? Because there is this in
Yeah.
pathophysiology that even after the second week, there is a second wave of neutrophil.
Yes.
Yeah. So for that, the same
You
steroid
don't need
tapering
you
will
don't
do.
need it. No,
Oh,
you don't need it. I see the purpose of steroids is to control the acute inflammation in the initial chemical injury stage. So you control it, you taper up the steroids, and your whole focus should be on ensuring that the epithelium heals as quickly as possible.
okay.
Re-epithelialize the surface. So the problem with continuing steroids for a longer duration is it also retards the epithelium from healing quickly. So you use it intensively for the initial few days, and also you should also keep in mind the grade of the injury. If you are seeing that it is a grade 1 or grade 2 injury, you can taper the steroids off in a much quicker fashion. Also, you can give steroids 2 hourly for 7 days, then 6 times a day for a week, and then 4, 3, 2, 1 for 5 days or 3 days, and just finish it off. There
Okay,
is
sir.
no need to use a weaker steroid. There is no need to use topical steroids for a much longer duration than needed. The
Oh,
role will be initial in the initial couple of weeks. That's it.
thank you, sir.
Ah, pleasure. Okay. So, are there any further queries? I'll be glad to answer them.
In slate,
Hmm.
the
Hmm.
epithelial, the transplantation done in the limbal area or over the cornea also, like in the
Over the
picture.
cornea. Over the cornea.
Oh,
You the slit surgery is such that you cut the limbus, you cut the limbal epithelium off from the healthy conjunctiva. You take 1 clock hour from the healthy eye of the limbal epithelium. You bring it off to the other eye with the complete LSCD, complete limbal stem cell deficiency. You cut up the epithelium into multiple small pieces and use fibrin glue to stick it to the surface. Okay, and we use amniotic membrane as a scaffold. You stick it and I will just show you the picture. You stick it to the cornea, not over the limbus. You just stick it to the cornea. So yeah, if you look here, I will just zoom in if possible. I can't zoom in, I think. Can you zoom in? Yeah. So you can see these dots. So this is where you have placed the tissue. You place it paracentrally. You will cut it up into 10 to 12 pieces, place it paracentrally, and just leave it. And if regarding the placement of graft on the limbus, that is also done, but that is conjunctival limbal autograft. That's a different surgery from slit.
okay.
You can actually see these videos on YouTube. Dr. Sayan Basu has some excellent videos on YouTube on slit. You can look it up. It's really a magical surgery. I've seen the results and it's miraculous.
So we need to put the
Right.
glue over the glue. We need to put these cells.
Yes, yes, yes. You can't put that directly. You have to put some fibrin glue to hold it in place, right?
Okay.
And you have to put a BCL over it. Otherwise,
Oh,
it will migrate off.
okay. Thank you.
You can see the video. It will get videos on YouTube. You can just search it. There are very nice videos are there. You have to use an amniotic membrane as a scaffold and everything, but that will be going into too much detail for this class. But yeah, you can look it up on YouTube.
Okay. Thank you.
Right. Sure. Are there any further queries? Yes, sir.
No, I was just asking the same thing.
Yeah.
That presentation was very like
Well,
crisp and to the point, and practically
yes. Thank
everybody
you.
will be able to manage also like the chemical injury cases.
Yes.
So if
Thank you,
there are
sir. I
no more
think,
queries, I
yeah.
thank you
Yeah.
and thank you for your time, Dr. Anivan. Thank you.
My
We
pleasure, sir.
really
Thank you for
appreciate
the opportunity.
actually Dr. Muthuswamy had mailed many people, but most of the people have not answered. So this is
Yes.
like we need to understand that we need to give back to the community and our if we can like at least help other people in some way, that also actually feels gratitude in them and also it makes us better. And thank you. I think Dr. Anivan, and I think we can close. And any other questions, they can be answered on the Telegram group.